Hello, this is Dr. Nedelman bringing you For Your Health. We have a session today dealing with primarily skin lesions. These are things that many patients come into the office and are concerned about. And I have the honor of having Dr. Kroumpouzos, Dr. K we call you.
Dr. K.
George. George, why don't you introduce yourself and tell us where you're from, where you got your training, and where your practice is now.
I received my dermatology training at Boston University Tufts program, and then I was on the faculty at Harvard and Brown. I currently practice in South Weymouth, Massachusetts, and I specialize on a wide spectrum of skin diseases, including connective tissue disease, skin cancer, gynecologic dermatology, and pigmentary disorders, among others. So,
your office is in the Stetson building in South Weymouth.
my office is in the Stetson building in South Weymouth, and we provide a wide spectrum of medical and cosmetic services, as well as skin cancer surgery.
Many patients come into my office and concerned obviously about skin lesions. And in the back of their mind is melanoma. The vast majority of them will have seborrheic keratoses, age spots, liver spots, whatever you want to call them. And basically, to the trained eye, you can look at these and tell that they're not melanomas at all. I mean, how do you deal with patients who are concerned about the development or the progression, get crustier, get larger as they get older, for these benign lesions, not cancerous?
I think we need to examine the patient first and let the patient know that these benign lesions can grow over time. Patients can develop more and more seborrheic keratosis the older they get, and this is quite common. Sometimes these lesions develop inflammatory changes or become itchy, as you mentioned. The patients are concerned or bothered. In this case, we need to remove the lesions and offer some relief to the patient. On the other hand, we need also to let the patient know that these lesions do not have these suspicious features that the melanoma has. And I think in my presentation today, I will show some cases where we see those suspicious features of melanoma. We should also encourage the patient to visit dermatology or primary care office and have lesions examined when they see changes.
So change is important. Now, there are certain criteria that you use in examining a lesion, the ABCDs. Could you go into that? Can we see this slide that we have up here now? It's a little small, but could you elaborate on this a little bit?
Absolutely. This slide shows the ABCDE criteria that we use to analyze and evaluate pigmented lesions. A stands for asymmetry. We see that on the upper right corner of the picture that there are two lesions there. One is symmetric and the other is asymmetric. Asymmetry is one of the suspicious signs. B stands for border.
Well, if we can, a moment. A lot of people that I see do not understand symmetry versus asymmetry. Could you elaborate? In other words, you would draw a line.
If you draw a line that can divide the lesion into equal parts, then the lesion is considered symmetric. If there is no way you can draw a line to divide it into equal parts, it's asymmetric.
Okay, very good. Please, yes.
So the second suspicious feature starts with B, and it is border irregularity. If a mole has smooth and round border, it is fine. But if a lesion has an irregular border, that is a suspicious sign. And irregular means blurry, indistinct, or jagged border. The C letter stands for color irregularity. If the color is uniform and even, it's fine, but if the color, if there are more than 2 or 3 colors in the same lesion, that is a suspicious sign. D stands for diameter, and usually lesions less than 6 millimeters are more likely to be benign, where lesions larger than 6 millimeters or 1/4 of an inch are more likely to have some suspicious features. And finally, the letter E stands for evolution over time. A mole that is stable over time is most likely benign, while a pigmented lesion that changes substantially over time can be a malignancy.
I've heard E referred to as elevation. Is that, or is it evolution?
Evolution.
Evolution.
The E refers to evolution over time.
So if something becomes thicker or higher in elevation, is that significant?
Occasionally it can be a significant sign because sometimes the elevation or becoming thicker indicates a vertical growth of malignant melanoma cells. So this nodularity or increased thickness can be a concerning sign.
Now, when you refer to melanoma, you're referring to a cancerous lesion. Malignant melanoma and melanoma are one and the same thing. Okay. Well, what does that represent as far as cancer causing deaths in the United States? There was one article I read, it was 4 or 5% of all.
Exactly. And the incidence of melanoma is increasing in a very scary way in the United States. It is estimated now that the lifetime risk is 2% of melanoma. That means 1 out of 50 persons will develop melanoma in their lifetime. So far, we haven't found ways to decrease that incidence of melanoma, and dermatologists and primary care physicians also focus on early detection in order to improve the outcome in these patients.
Well, do they have to fulfill the A, B, C, D, E criteria, or might you have a melanoma without these, or just 1 or 2 of them?
Absolutely. Sometimes they don't fulfill the A, B, C, D, E criteria, and these are the difficult cases, difficult for the patient and difficult also for the physician who sees a specific lesion. For example, a nodular melanoma that is perfectly symmetric and very dark brown and grows and like a symmetric nodule may not fulfill any of these criteria if it is less than 6 millimeters, because it may be perfectly symmetric, it may have a round, smooth border, very dark color, and still be a threatening malignancy. So I think in these cases, the patients should be encouraged to see the dermatology or primary care physician as soon as possible when they see something changing, because we don't want to miss those cases.
Change is the important thing of any one of the criteria, A through E.
Exactly.
Change. We have here, if we can go to the pictures, could you describe this to us, please?
This is a superficial spreading brown lesion that has asymmetry. As we can see, we cannot draw a line that can divide it into equal parts. It has many different colors. There are many different shades of brown as well as a dark brown area. So the color is uneven, and the border is jagged and irregular. It's more than 1 centimeter, and this has evolved over time. It is highly suspicious for malignant melanoma.
And how large might this be? There's no scale here.
It can be extremely large. If the patient misses the spot or neglects it, there are neglected cases where the patients don't go to physicians promptly. These melanomas can grow to various centimeters or even inches large.
And how small might they be? If you see something like this with your special scope, how small might they be if you see them?
When they come to the doctor's office, they're usually more than 6 millimeters, and when they have different colors, so any specialized physician in dermatology can see that difference. However, there are challenging cases where the spots can be very small, and that's when the patients usually miss the change.
And 6 millimeters, you would say, is about the size of a pencil eraser?
It's about
the
that
diameter of a pencil eraser. And what would the patient normally say to you? Doctor, I've had this and it's developed in the last month, the last 6 months, the last year. What sort of story would you get?
It's usually that story. Patients either come and say, oh, I have had this for a while, but now it's changing. Or the patients say, oh, I don't think I ever had that spot there. I think maybe new. This is usually what the patients can recall. They can recall the exact features. Sometimes it's extremely difficult for the patient to recall how it was a year ago. But often they recall that there is some change there.
And would you expect that a lesion like this, if it's been there, say, for 6 months, would have spread or metastasized already?
Usually not. Usually the lesions that have been there less than 6 months, they do not metastasize, usually. But the metastasis risk relates to the tumor thickness. Statistically and mathematically, that's what we know. So it's the tumor thickness that usually tells me, the tumor thickness in the pathology report that usually tells me if it could have metastasized or not.
The thickness from the skin level down, in other words, the degree of penetration.
A degree of penetration. Usually when the melanoma is less than 1 millimeter, it's very unlikely to have metastasized. The risk of metastasis for melanomas that are less than 1 millimeter thick is only 5%, while the risk of metastasis for melanomas that are more than 4 millimeter thick is 40%. So we have between 5 and 40%, and we see that this risk increases with the thickness of the melanoma. So the pathology report is extremely important because it tells me how likely it is that this melanoma could have traveled to the lymph nodes.
All right. Could we go to the slides here again? And what do we have here? We have 2 lesions, the one on the left.
The one on the left shows a melanoma, and this slide indicates a very, very important prognostic sign, which is the presence of other smaller lesions around the main one. When a melanoma starts showing those other tiny lesions, so we can see a cluster on the lower part of the photograph. These are called satellite lesions, and this is a worrisome sign. When a melanoma shows satellite lesions, this is a bad prognostic sign. The picture on the right shows bleeding from a nodular melanoma, a melanoma that is thick, and bleeding is also a worrisome sign. So when one sees those signs, the presence of satellite lesions and the bleeding, one should be worried that the melanoma may have already metastasized.
Now, the one on the left here with the satellite lesions, would you have normal skin in between these lesions? You would.
There is often normal skin in between, but the way these lesions cluster and their color is very similar to the color of the main lesion, so that tells me that it's all satellite lesions.
And how do these satellites get out there? Have they been through the lymphatic?
Usually through a local lymphatic spread or a non-contiguous spread. Sometimes we see that the melanoma cells can be beyond the visible margin, beyond the clinical margin, and that also manifests itself as a satellite spread.
So these have definitely metastasized.
It's very likely that these have metastasized to the regional lymph nodes, which is the first place a melanoma would go is the regional lymph nodes.
And this is true also of the one that is bleeding.
Bleeding and ulceration are bad prognostic signs. Usually those spots that bleed have a substantial thickness in most cases, and again there is a higher risk of spread to other sites in these cases.
I see. Well, time has gone by very quickly. Is there anything you'd like to say in summary, in closing?
I think patients should be familiar with the ABCDE criteria. When they see changes, they should see their dermatology or primary care providers promptly. We should not miss the early melanomas. They're all curable, and we should advise the patient to seek help fast. Patients should not neglect, should not deny that there is some changes somewhere, and I think we need to also show to the patient how to do their self-examinations. Periodic self-examinations are advisable, and they can help detect melanomas promptly. If we diagnose melanomas early, that's the best thing we can do at this point, because there is no effective treatment for metastatic melanoma. So our focus should be to diagnose these lesions early and not to miss them.
I hope we can get you back again to talk on another topic.
Thank you. I would be delighted, and
And
I thank
I
you.
thank you. Thank you. This is Dr.
Thank you,
Nedelman
man. Thank you.
for your help. Thank you for watching. You're very welcome.